Roy Boukidjian is System Director of Infection Prevention at Dignity Health in San Francisco. He has board certifications in infection control, public health, and he's a nurse executive with a master's in nursing leadership from California State Fullerton. He currently serves on the Hospital-Acquired Infection Work Group for Policy and Legislation, headed by the California Hospital Association and the California Department of Health. Roy has served as president of the Tri-Valley APIC chapter in California in 2014, and he is a hero of infection prevention. That initial award happened in 2013, and I understand his system is going to receive another award this evening. So congratulations. So with that, I'm going to turn it over to Roy.
Can you guys hear me?
Echo? No? Yes? Yes? Okay, echo. Hello, everybody. Thank you for coming today. I know it's the last day, so thank you for being with us. There's really good information. Hopefully, we could have an exchange. All right, so back in October of 2016, a roundtable of experts came together at ID Week, and Ruth and I were fortunate enough to be on that roundtable to discuss probe reprocessing challenges in general. And those proceedings were eventually published in Infection Control Today. So what did we talk about? Well, we talked about a couple things. We talked about adherence to guidelines, gaps in current guidelines, who's accountable for oversight and training for probe use and reprocessing. Is it the IP, really? Is it the radiology director? Who is it? How IPs can be prepared to respond to Joint Commission CMS. We discussed a survey of APIC members that was sent out a while ago, as well as the expansion of ultrasound probe procedures across the healthcare system. So not only to departments, but healthcare system in general, if there is a system, impact of that expansion on infection risk, centralized versus decentralized reprocessing, and of course, manual versus automated reprocessing. So there's a lot to cover. We also discussed the CDC alert that was published in 2015 that basically said healthcare facilities should review the cleaning, disinfection, and sterilization procedures of medical devices. In addition to that, the Joint Commission Safety Advisory back in 2014, based on 2013 data, identified 7 out of 13 immediate threat-to-life events due to HLD and sterilization. And I'm not sure if you guys saw last month's TJC Safety Advisory Alert. They mentioned the same thing last month. So it's definitely on their radar. In addition to that, there are other alerts out there, such as from the UK, where the alert identified a patient unfortunately passing away due to a Hep B infection, potentially due to a TEE procedure. That TEE probe was unfortunately not properly disinfected. So there are similar agencies, similar to the FDA, that released alerts across their country to indicate ultrasound disinfection practices should be reviewed. So current guidelines in the US. There are current guidelines in the US, believe it or not. Some are ultrasound specific, some are more general. They are harmonized in the recommendations, but it's hard to synthesize across all documents. The proliferation or the expansion of ultrasound throughout departments are not addressed. And I actually had a small conversation with some of my team members yesterday, and we're like, oh my God, we should take a look at this. And of course, the recent clinical research were not covered in those past guidelines. So guidelines exist today in addressing probe reprocessing. So some of those guidelines. So the American Institute of Ultrasound and Medicine and CDC in 2014 and 2008 respectively, they all came together and basically agreed that semi-critical and critical ultrasound probes must minimally undergo HLD even if used with a probe cover. In addition to that, the FDA, AAMI, Joint Commission, in relation to standards and regs, also agree that semi-critical reusable medical devices should undergo HLD. So you'll see this common theme as we go through this, that all these agencies or regulatory folks or even standards and guidelines, they all agree on the same principle, which is rare. It's rare. So in relation to a global aspect, again, there are guidelines out there that actually agree with US guidelines. Go figure, there is. There's guidelines from the UK, Ireland, Australia, the World Federation for Ultrasound in Medicine and Biology. They all agreed from the aspect of high-level disinfection of semi-critical ultrasound probes. Some of those guidelines include the Scottish, Irish, again, oh, and then something very interesting, the Australian College of Infection Prevention and Control and the Australian Society of Ultrasound in Medicine actually came together and created a joint guideline in relation to this specifically, which is the first. So they all indicated that, again, semi-critical ultrasound probes, intracavity or surface, must undergo high-level disinfection even when we use a probe cover. So challenges in the US. Well, there's a couple challenges. One, again, variety of clinical staff doing the procedure. Who is it? Is it the PIC team? Is it the perioperative team? Is it the radiology team? Who is it? And of course, again, the variety of the procedures out there. So it is challenging to keep track. You know, when I ask an IP, so, you know, where are your ultrasound probes used? I'm like, oh, well, we use it in radiology. We got a women's center, maybe oncology. And we don't think about it everywhere else. So it is very interesting to see where the knowledge gap is. So I would encourage everyone to ask yourself, where in my hospital are semi-critical ultrasound probes used? Seriously, where? And are we correctly classifying the procedure according to existing US guidelines? Is it a semi-critical procedure? Is it a critical procedure? And so on. So the Australian guideline actually assisted their country to identify what needs high-level disinfection and what doesn't. And one thing that's very interesting actually here that blew my mind, they actually classify PIC insertion and CVC insertion as requiring high-level disinfection. And when we think about it, like, okay, why is that? Because practically no one does that. And I asked my radiology director at one of our facilities, so what do you do? I mean, technically, it's a sterile procedure. You technically drape the patient from head to toe. You're wearing sterile attire. Everything's sterile. But your probe is not. Now, your probe cover is, hopefully. And supposedly, the process is you just wipe it down with a germicidal wipe. So it is very interesting to see how the practice is. And when we look at the guidelines and identify what procedures actually constitute a semi-critical procedure and critical, the thinking changes a little bit. So the table addresses the proliferation, actually, in multiple departments. So radiology, OB, vascular, cardiac. Also, again, oncology, they use them as well. And again, they all agree about high disinfection in these type of procedures. So some clinical updates I want to share with you. So the probe handle of our lovely ultrasound probe needs to be disinfected. Dr. Alpha in 2015 published an article that basically said that it is imperative that guidelines and healthcare policies are updated to ensure that vaginal ultrasound devices are handled as well as the probe handle or head are adequately cleaned and disinfected after every patient use. So there's a couple of studies that show over 80% of probe handles are a reservoir for pathogens, and that's why we want to highly disinfect the handle itself. Not all probe hands can be immersed in liquid solution, as many of us know, and we know for a fact that there are technologies out there that actually do this type of procedure or process. So HPV. So this is not new, probably to none of you. HPV contamination in connection with high-level disinfection has been on the forefront of many articles, and that's basically what the slide is showing you, that there is information out there as far as HPV contamination. So obviously, there are multiple strains. They cause over 99% of cervical cancer. They are transmitted through sexual contact. Though, interestingly enough, there has been some studies to show non-sexual transmission. You ask, like, how is that possible? HPV infection in children, the study showed that it was actually transmitted in the prenatal phase, which was very interesting. And then 2 studies showed, one in a community center, one in a university hospital, in which HPV DNA were identified on fingertips of the infected individual. So again, some additional studies, 43.8% of scopes were contaminated with HPV in an OB clinic that was identified. 3 to 7% of ultrasound probes are contaminated with HPV DNA after reprocessing. And as we all know, HPV is resistant to disinfection and desiccation and remains infectious on a dry environment for several days. So it is a problem. So some studies were published actually in basically comparing, you could say, high-level disinfection procedures for these probes. And it was clearly identified that an automated hydrogen peroxide device is effective against these native HPVs according to FDA requirements. So it is tested per FDA, which is the key here. You know, many folks say, well, you know, Roy, it's not only about the disinfection. It's about the entire process. You know, the cleaning, the transportation, the high-level disinfection, the handling, the storage, et cetera. And I get it. That's very true. However, if you just compare solution itself, we know for a fact that OPA does not kill HPV, and hydrogen peroxide in an automated system does. That's the takeaway. All right, so we talked about what type of procedures could be semi-critical or critical. Well, here's plenty. Ultrasound-guided biopsy, ultrasound-guided central venous access, abdominal paracentesis, intravascular procedures, thoracentesis, et cetera. So you can see there's a lot of procedures out there that ultrasound probes are used in which we, as IPs and professionals, would want to know and identify whether we're actually processing our ultrasound probes correctly. So when I first looked at the right side and saw all these departments, it's, you know, departments in which procedures is carried out. Instead of reading all that, it's just everywhere. That's the answer. It's everywhere. Okay. So again, in 2008, actually, CDC also produced some guidelines, and surface probes used in sterile procedures must undergo HLD. So the question to you all in this particular picture is, you know, is a sterile probe cover used? Is that a sterile rubber band? I've never seen a sterile rubber band. Is anybody? I don't know. Seriously. Is a sterile single-use gel used? And if the probe has minimally undergone high-level disinfection. So something to think about. Oh, this is fun. So when I saw this, the European Society of Radiology produced a survey back in 2015. So when I first saw it, I'm sitting down on the screen right in front of me. I looked at it, then I looked back. Then I looked at it, then I looked back. I'm like, no. So then I call my wife. I'm like, Beth, come here, sit here. What does that say? And she's like, blah, blah, blah. I'm like, what? Really? Okay, thank you, goodbye. Then I pick up my 15-month-old daughter, put her in my lap. I'm like, what does that say? And she's like, blah, 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 blah. Okay, I'm like, okay, you're done. Thank you very much. But it's a very interesting survey. So the European Society of Radiology conducted a survey. 900 plus radiologists responded. 97% were radiologists, 946 total respondents. So obviously, you can see the mass majority were radiologists. And I looked at surface and endocavity probe disinfection practice. Here's the kicker. Oh, no, actually, it's the other side. OK, a little bit more data. So 26 or 2.7% were aware of cases of HAI transmission through ultrasound procedures, which is interesting. It's like, well, OK, that's very interesting. And they identified in the survey that the procedures that they believed caused that transmission included breast biopsy, joint aspiration, transvaginal ultrasound, and transrectal biopsy, which is very interesting. And the presumed transmitted organisms, MRSA, Staph aureus, CMV, HPV, and fungal infection. Here's the kicker. So the endocavity ultrasound probe reprocessing pie over there, if you look at it, it said, the survey said 69%, they wiped off the gel first, and then they just wiped it with a germicidal wipe. And this is an endocavity procedure. I love the 9%. It says wiping off the gel first, and then they wipe it off at the end of the day. So it's like procedure. Oh, and then I wipe it. Very bad. And in relation to interventional procedures as well, the results weren't good. So it was truly a shocker when I read that. That's why, I called my wife. I called my daughter. I'm like, please help me read this because I speak no English. So it is definitely an eye-opener. So on-the-ground observations. One ultrasound probe can be used in different capacities. Probe can be used for both gallbladder evaluation as well as paracentesis. And this is actually some conversations I had with my radiology director at one of those facilities, that do not assume one device is only used for one thing. It's used for multiple things. Radiology department is not responsible for all ultrasound probes. That particular director said, you know, I just manage probes here, but I don't know what they're doing at the Women's Center. I don't know what they're doing in oncology, et cetera, et cetera. And that's a big problem. Facilities assume that a sterile cover is sufficient during sterile procedures and no HLD is required. And of course, ultrasound gel use differs from facility to facility or even department to department. You talk to the radiology department, they say, oh yeah, we use single-use sterile gel packs. I'm like, oh, good job. And then you go to the OB department or the Women's Center. Oh, you know, we just refill the bottle. I'm like, well, come on. I mean, you're in the same facility. You're literally 3 minutes away from each other. Get it together. So as far as automation is concerned, as we all know, endoscopy automation has been a lifesaver when we're processing endoscopes, okay? It reduces human error, improves standardization of practice, simplifies the workflow, and eliminates the handling of specific chemicals, or if you need a fume hood, and if you have the right air exchanges above that, et cetera. And same thing with ultrasound. So new technology is available that would allow us to reap the benefits similar to the benefits of your automated endoscope reprocessor. And it permits safe processing in procedure rooms at point of care, and that's what we'll touch base on a little bit. So reason for point of care. Well, a couple reasons. One, we know that ultrasound probes are everywhere, so centralization is very hard. It avoids mixing up scopes during transportation or storage. It avoids probe damage during transportation. And of course, the sheer volume of ultrasounds you need in a hospital could increase significantly if things aren't where they are for immediate access by the clinician. So the barriers, well, some barriers some would think of is safety first. You know, is the chemical safe to utilize in that point of care area? The cross-contamination of clean devices depending on what your process is in that point of care location. And of course, the notion of centralized reprocessing allows for better control. And from a high-level aspect, yeah, it does. And that's why a lot of people centralize endoscope reprocessing with sterile processing, et cetera. But when you have a proliferation of ultrasound probes everywhere, centralization practically probably will not work. So point of care is possible. It's beneficial. Technologies do allow it. The enclosed systems that are available now and the probe storage covers prevent that cross-contamination. And of course, again, easy handling and convenience. I always tell this to folks that ask me about a product. What do you think about this product? And it might be the best product in the world. But the answer is, if it's not convenient, it doesn't matter how good your product is. It's not going to be purchased. It's not going to be used. That's your primary piece of information. So if it's convenient for staff to use, regardless of how great it is, that's your golden nugget. So key takeaways. So again, guidelines and practice and standards do exist today. So please utilize those guidelines if you haven't seen them before. Again, remember to ask yourself, where in your hospital are semi-critical ultrasound probes used? Are they correctly being classified? And who's classifying them? Like literally who? The frontline staff? Is it the department leader? Who is it? Look at local policies that should address reprocessing endocavity and surface probe that are used in these particular conditions. Look at sterile probe covers. Again, sterile single-use ultrasound gel during these procedures. And identify an accountable source. Hopefully, it's not an IP accountable source, but an accountable source for these procedures. And with that, I'll hand it to Ruth. All right.
Dr. Ruth Carrico is Associate Professor and Family Nurse Practitioner with the University of Louisville School of Medicine, Division of Infectious Diseases. She's also the founding Associate Director of the School of Medicine for Global Health, the School of Medicine Global Health Initiative. Ruth has served as an editor of the APIC text of Infection Control and Epidemiology and on the APIC Board of Directors. She was 16. The Certification Board of Infection Control and Epidemiology, responsible for board certification for infection preventionists worldwide. And I hope that you're all certified. If you're not, that absolutely needs to be a goal. And she's also editor of the University of Louisville Journal of Refugee and Global Health, which was launched in 2016.
Thanks very much. Boy, Roy's a hard act to follow. If he had brought his daughter with him, there would be no way, absolutely no way. She is an absolute angel. Well, you know, some of in listening to this and in learning more about this, one of the takeaways that I get is that, you know, I recognize that our staff are doing what they think is the right thing to do, right? And so their job is trying to address the needs of the patients, follow and then go with what the providers are telling them, and go with the processes that have been enabled in our particular facility. So this kind of circles back to what our roles are as infection preventionists. In addition to looking at our outcomes data and looking at the bundles and looking at everything else that we're doing, we also have to be looking at what is occurring and kind of where is the future taking us, and looking at new processes and new products that are entering our facility, new procedures that are being done, and how that impacts the safety of our patients. So as we look at ultrasound use, we all know that this has been an explosive process. I hope I'm going to push the right button.
The green one on top.
On top, okay,
Yep.
perfect, great. We know then that we have had, over the course of our careers, we've seen a number of changes occurring and how patients are cared for and what is involved in that care. And as I look at what we are seeing and enabling, you know, we're having to figure out how do we get patients in and out more quickly? How do we provide then rapid diagnostic capabilities more quickly? How do we do this in a variety of settings? It's not just in the hospital. It is the expansion then of care across the entire continuum. And in the past, we have looked at the use of ultrasound very differently. We've looked at it as a very benign process. I bet if you walk up into a patient care area, in just about every patient care area up there in the cabinet, there's going to be a Doppler that's tucked away back there that's used to check pedal pulses or for some other purpose. And it just kind of sits on that top shelf and is pulled out occasionally to plug in or change the battery, but without thought about what are we using that Doppler for. And our brains have been occupied in a number of other areas, but I think this is one that we are going to have to look at because of the application and really the explosive use. If we look at where the use of ultrasound and all probe uses are occurring, the numbers of these procedures is increasing. The places where this is being used is increasing, as is our jobs. So we are then involved very few of us just have one small facility to deal with, that we have then a conglomeration of facilities, clinics, offices, and so forth. So we're really having to get to know what is happening. And as we look at where healthcare is being paid, you know, where can it occur in the lowest cost setting so there can be appropriate payment for the cost of service, then we're seeing ultrasound use then that is popping up in places that we never thought. So in addition, that it's giving us a cause to get to better know the actual procedures themselves. I remember when at my facility some years back, the vascular access team said, you know, we're tired of blind sticks. You know, we've got to have ultrasound. And we began to look at then equipping that entire team with ultrasound devices so they could locate not only veins for PIC insertion, but also peripheral, those really tough peripheral line insertions. And we began to look at the procedure, and the team was telling me, yeah, we're going to use a probe. And so that means, you know, with the probe, we've got to have sterile gel. And it was that introduction of that thought process that really had me begin to think about, I wonder all the other places that we're using these probes. Are we thinking this through? Again, have we enabled staff to perform effectively? And that means that we need to bring in that level of knowledge and a looking broad spectrum at the process to help them make those decisions. So when we start to think about where is ultrasound being used, the numbers of places and for the numbers of procedures and in the numbers of departments is really mind-boggling. So if you go back to your facility and you start trying to say, you know, where can I look and where can I find this use, that I think that you need to really be willing to spend a good portion of the day saying, all right, if I'm going to start this process of understanding practice in my facility, I'm going to have to make sure that I'm spending time getting out into each of these areas and then asking some key questions. Now, a long time ago, we used to be able to say, I can find out where a device is undergoing some type of chemical disinfection, because I can go to purchasing and I can say, tell me every department that perhaps purchased glutaraldehyde. And then I could say, okay, do I know what's going on? And I can follow it that way. It is becoming increasingly more difficult because it seems that every single department has use for ultrasound. And then our job is to go and enable them to do the right thing because we know that's what they want to do. They may not be focused on some negative outcomes. They may be totally unaware, or like the physicians will tell me, you know, I depend on the facility to make sure that I can't screw some things up. You know, I need to make sure the products and processes are in place so I can't make an error, but I can't think entirely through this process because that's not my area of expertise. And I really love it when they tell me that, because then I know that they are looking for partnership. But look at all of these, anything from just being used on the skin surface to being used in an operative setting, the full spectrum of where we are seeing probe use. Now, our problem always involves how do we make sure that we are applying then best practice and standard approaches across the healthcare organization. So how are we making sure that every place then that is going to be using a probe where it's going to be coming in contact with non-intact skin, or it's going to be used in part of a procedure where at some point we're going to pierce the skin, how do we make sure that every place that does those procedures has access then to processes that not only meet the standards, but are performed consistently? This also is a reminder that this is not just a Kentucky problem, where I'm from, or a U.S. problem. This is a worldwide problem. And just like we've had guidelines from the World Health Organization on hand hygiene, we are learning then that we need to be cognizant of what is being developed outside the U.S. and learn from their experiences, so we then can figure out how we can incorporate that into our practice. What we do know is there is a gap in knowledge regarding where the procedure is occurring and the processes that are used and the standard approaches. So let me just kind of give you an example. Here's a scenario that I'm sure happens in your facility, happens in mine. We have a provider that's going to perform a kidney biopsy. They have then an ultrasound probe, they have gel. They're going to be taking that probe, or that needle and syringe, the piercing for that biopsy, going through the gel into then that organ to retrieve then a piece of tissue. So without a probe that is adequately protecting that gel from contamination, that gel then cannot serve as a barrier, microbial barrier of sorts, for the introduction of that needle beyond the skin and then into the kidney. So we have to be looking not only at the probe itself, but everything around that procedure that is going to prevent that endpoint. That endpoint is we're trying to prevent the introduction of microorganisms past their body's first line of defense, which is their skin. So a number of holes in the cheese have to all line up for prevention to occur. So here we have a couple of pictures, you know, on the side with the red X. This seems to be what I will walk in and I will see a provider that is just in too big of a hurry. and they're not taking the right protection for the patient. They've got the probe, they're trying to find whatever it is they're looking at. Am I going to be trying to aspirate? Am I going to be trying to biopsy? No gloves as their protection, no gloves for protection of the patient, no sterile gel, no probe cover, no skin disinfection likely, unless it was an alcohol swab, a quick little rub. And then compare that then with the picture on the other side, where this has been done much more appropriately, where we're thinking about what is it that we're going to be doing, how might we introduce infection to that patient, what are our practices that need to be in place to save that patient from needless exposure to a preventable event. So anytime we're looking at a process, I think the best place to start, and all of us will agree, is let's look and see if we're going to try to achieve best practice. Our starting point has to be, well, what is actual practice? So we can then determine how big the gap is, where the gap is, what we're doing right, and what needs to be corrected. And last October, that there was a survey that went out to individuals, about 100 individuals, or at least 101 respondents, APIC members. And the questions were, what is current practice regarding reprocessing of surface probes in looking at semi-critical and critical procedures? The focus, really three big areas. One is focusing on the probes themselves, how they're reprocessed, and then what types of strategies support appropriate use of best practice care. So these results, I think, will be surprising. They were certainly surprising to me and raised a lot of questions. All right, of this survey, only half of the respondents used high-level disinfection and sterilization for surface probes. Now, many of the respondents, a majority, actually worked in acute care settings, so that is going to be a little skewed toward those in acute care. But I think this is important because I would challenge you to dispute this. If we do things well in acute care, I think we have a better opportunity to do things well in other care settings that we also have a responsibility for. So the question was, do any departments or clinics in your facility or your integrated network use high-level disinfected or sterilized surface probes? It was 50-50. About half do not. So this, I think, is a concern, right? Because we know that procedures are going to be occurring where we should have access to this. The question then again was, which of the departments use high-level disinfection or sterilized surface probes? And you can see, and it really just mirrors what Roy showed, look at the places where probe use is occurring in these facilities. So broad use of a procedure then that potentially places patient at risk without appropriate procedures being used. This is kind of our first take-home point. What do we know about these types of probes? We have semi-critical, critical ultrasound probes are used in invasive and semi-invasive procedures, and that is occurring in a variety of departments. Our first recognition. The proliferation of the use represents a challenge for us to not only know what is occurring, but then come up with a plan of action. And that making sure that we are looking at technologies that are available to do exactly what Roy mentioned, that if we make it hard for the people to do the right thing, they will not be able to do it. They will develop their own workaround plan, because they are trying to achieve the objective of providing care to the patient, and then that is the assumption that they will have access to what they need in order to accomplish that. We have to make sure that it is occurring, and so we have to be keeping track of not only procedures that are being done, but practices that are being used. All right. We also learned in this survey that we don't have enough manpower, woman power in infection prevention and control departments. So we know that each of us is under-resourced. We are trying our best to get out there and see what is going on, but about 71% of the respondents had just a one-person or a small designated team to look at all of these issues. And so I think that although our inclination is to say, well, if it were important to my facility, then there would be more of me, But I think then that's we're kind of assuming and we're giving up then responsibility and accountability and leadership in this. And so our job has to figure out who are our partners then. If we can't do this, who are we going to partner with in order to get this done? But recognizing that this is a distinct challenge, and certainly we all know that. All right, well, how should departments choose this disinfection method for their probes? And this goes back to our thought about risk assessment, that we've got to understand what are these probes being used for, and then follow then our thought process with respect to Spalding classification of the Spalding criteria. What are we doing? What is it used for? What does it come in contact with? So for example, if we have a probe contacts sterile tissue or blood, what is it used for? What departments are going to be performing these procedures? This is a need for a critical, it is a critical device. And then if the use is critical, then we've got to figure out how we're going to provide either sterilization or, depending upon the instrument, high-level disinfection, and then use a sterile probe or sheath, or sterile sheath over the probe, and sterile gel if that is needed. So knowing our procedures, knowing our equipment, and then helping staff come up with an easy way to figure out and make those decisions can offer us then a high probability for success. All right, so then the next question looked at ultrasound-guided biopsy. So how often is this happening, and what is happening with your approach to disinfection? So when the question was posed about what type of disinfection do you use, almost 40% said low-level disinfection or cleaning without disinfection. Well, what about the use of gel during ultrasound-guided biopsy? Look at the number. Almost 33% use a multi-use gel bottle, or sometimes they use a multi-use, and sometimes we may use either sterile gel or unsterile gel in single packages. So a lot of opportunities then for not only contamination of that gel, but contamination at the time of that biopsy for a single patient. All right, what about a cover over that ultrasound probe? About 40% no probe cover. And even, let me go back. Oops, if I could go back. Back? Oh, I better not start pushing the buttons because I don't know where I'll get us. But I think look at the little box at the bottom, the number that weren't sure. So a couple of things about this survey that kind of I want to hit the pause button for a minute. That the results of the survey, when I looked at it, said to me a couple of things. A lot of us don't know what is happening in our facility. Now, it's not that's not a, bad Ruth problem. That reflects then the fact that we've got new procedures that are coming up, and this just hasn't made it to our radar, right? So a good portion of the respondents didn't know the practices. Again, when you go through and you look at these results, when you start thinking about them, you're like, wait a minute, you're answering yes to this, but you're answering no to this. So it's telling me that you're not really sure what you should be doing in these situations. So not only do we not know practice, we're not sure, or we ourselves are having trouble following a thought process through what should be occurring. Okay, so this looks at a biopsy. How would your policy classify a surface probe? So what are you telling people in your written policy or procedure when you're going to have a probe used during an ultrasound-guided liver biopsy, where the probe is used with a probe cover or sheath? So you're looking at, a process where you're going to be using a needle, going through the skin, using the probe as part of that procedure. Almost 70% classified that as a non-critical or a semi-critical process. And then another 12% weren't sure. So only 20% saw this for what it was, a procedure where you have got to have a more critical use approach to those devices. Now, when we look at an ultrasound that's used during central line placement, when you go through the steps that are outlined in the CDC guideline, when you're using then a probe, if you're using that to find an artery, or, I want to stay away from this artery and I want to be over to this vein, you're trying to use that probe and provide that for your provider to know where to stick. That will come in contact then with skin. Perhaps it comes in contact with skin before there has been skin disinfection. or maybe it is after skin disinfection. But you can see the number of times then that probe is going to be going back to the skin throughout that procedure. And so how do we make sure then that the movement of that probe back and forth during that procedure is not a vehicle for microorganisms that will then contaminate the site where that line will be inserted? Because sure enough, who's going to be counting that as a CLABSI? Well, we may be, if we do not prevent introduction of those microorganisms at the time of insertion. So when we ask then about ultrasound-guided central line placement, almost 73% said they used low-level disinfection or wiped it clean. Now, when somebody says wipe it clean, I think about, when I went into my facility at night, that's where, a good proportion of our staff are that have less experience. Our more experienced staff seem to be those that are working day shift. And so if I knew that something awful was going to happen, I could usually figure it out if I would go and make rounds on night shift. And I just happened to see I work in an academic setting, I saw one of the medical students that had been assigned to cleaning the bronchoscope. How can that happen? Well, that's the trauma service sometimes does things there, they march to the beat of a different drummer. So that was bad enough that I saw him, and he was so sweet, and he was willing to tell me everything that he was doing, because he didn't know he was doing anything wrong. But the reason that I even noticed it was I saw this poor little medical student sitting there, and there was like a stack of opened alcohol swabs. And I'm like, I wonder what he's doing with all those alcohol swabs. Well, that's how he was cleaning the bronchoscope. And I know before you say, I am not going to a hospital in Kentucky. Okay. But I would tell you that I can almost guarantee you that I'm not the only place. It just may not be a medical student, but somebody's doing that because they think that's the right thing to do. They don't see that it is wrong. And we're seeing then in our practices that if we ourselves are not sure or we are not enabling best practice, how can our staff possibly be successful? When we looked at gel use during ultrasound, then we had 23% that use this multi-use gel that is in a bottle, that that those are going to be contaminated, right? I mean, we know that. We cannot prevent that. And then about 7% we're not sure. Using a cover during the central line placement, again, about 40% no cover. So our problem is we lack then of knowledge on a number of levels. We've got to make sure that we understand this, and this is part of that critical thinking that we talk about. We need to understand what needs to happen, why it needs to happen, and then figure out what that means for procedures and policies that either are developed or need to be developed in our organization. So we've got to make sure that we've got clarity in our minds as well. And then we've got to be able to convey that clarity somehow. Now, 92% of those survey respondents believe that having a standard high-level disinfection method facility-wide is preferable. I'm not sure about what happened to the 7.9%. I think they must have fallen asleep, because I think we all know if we're going to have success, then we've got to say if we are using a same procedure, then we've got to have a standardized way of approaching. A critical device is a critical device. And it needs to be viewed as a critical device no matter where it is being used, that we need to make sure that staff have the ability to do the right thing. And if we are not clear in what that right thing is and we don't enable them to do the right thing, how can we hold them responsible for being unsuccessful? We know there's a knowledge gap where semi-critical ultrasound probes are used, and this, I think, is directly related to the explosive number of procedures now that are occurring using these devices. And we're going to have some uniform standards. And those standards need to cross not only across hospital departments, but we've got to recognize that this same use is occurring in other healthcare settings. We are seeing this now in our medical offices, in our ambulatory care settings. And I think Roy talked about the intracavitary probes, that if we are thinking about, I work a lot with the refugee patients. We're seeing a lot of refugees coming in the U.S. that are spending significant time in some of the Zika endemic areas. We're working with them on birth control. When they first come, how do we prevent unwanted pregnancies? But if we're not successful, these are women that, according to the guidelines, are going to be having frequent vaginal ultrasounds. So now I've got to be thinking, where is everywhere that is going to be, that has vaginal ultrasounds? Well, it's primarily in the women's health area, but that's not only where that is occurring. So now I'm looking at some of the family practice offices. How are you then handling your vaginal probes? And that I'm concerned not only about the number of those procedures that are occurring, but then I'm concerned about HPV. Are we going to be facilitating simply because we're not able to get in our minds the thought about how to handle these patients in these situations appropriately? So our job is to always be forecasting. We're looking at what is occurring. We know about the standards for infection prevention and control, and then how are we going to apply those? And we have to then learn to work with our colleagues around the world. Some people that are looking at this that are really ahead of us in terms of their approaches. Just like we look at the World Health Organization and some guidelines, we've got to be looking at some of our other countries and saying, what have you done? And I think that we have some excellent examples from Australia on how this collaborative development of guidelines is critical. Now I want to end with a little bit of talk about the emergency department, not because it seems like 90% of my headaches somehow I identify through emergency department practices, but 90% of my headaches occur from seeing what's happening in the ER. They'll either tell me about it or I'll see it. So here we have an example from the literature looking at emergency department and some of the probes that are used. Now, you all know the focus of emergency department is we want to keep the patient alive and stabilize them until we move them or we discharge them. That the thought about preventing transmission of infection is somewhere in that, but it's not the top issue. So it becomes really important that we think about how do we implement then practices in the ER where it is detrimental to the safety of the patient, so it makes it hard for them to make errors. So in this study, they looked at ultrasound equipment across 5 emergency departments and 5 ICUs. 57% of the probes were contaminated with blood. That's the bad thing. All right. About half, almost the same amount, were contaminated with bacteria. So we know then that these probes are being used and reprocessed very sporadically. When we look then at a number of pieces of equipment, we know that it is not only an individual probe or ultrasound probe that is contaminated and not cleaned, but it's a number of other surfaces: gels, keyboards, transducer leads, work surfaces. So we know that we have specific contamination problems in areas where we have a lot of fast activity, high acuity, and without and you can't tell me that these people are not concerned with infection. Clearly they are. So we just have to recognize the work practices that are going on and then figure out how are we going to keep them from being able to do the wrong thing. And the wrong thing is to use contaminated items with the patient care processes. So in looking at this, there were a number of epiphany opportunities in looking at that first survey to say, wait, we really need to do a more thorough or a deeper dive in this and in taking a look. So a new survey is going to be planned, and we really would love to have you, any of you that really are involved and want to assist with the survey process. We want to be able to send this out then to APIC chapters and provide other avenues as well, where we can connect with people to say we need to know what is existing practice. What is existing practice across, and maybe have a larger sample size than 100. We want to know what is the level of knowledge, not only the knowledge of IPs, but what we are seeing in practice. We want to have a better understanding about policy implementation. What are some of the problems that we see in implementing then a standardized policy? How can we assure compliance or adherence with our policy? What is currently happening that would enable us then to look at perceptions and knowledge and attitudes and so forth on how we can structure better approaches. What do people feel like they need? What will help? Because if we say, well, just follow Spalding, well, that seems so simple, doesn't it? But this is an example where it is not a simple decision. This is not a decision tree. This is a bush. right? A lot of places that this is going. And then we've got to make sure that people understand, why are we concerned about this? It's because there are risks involved in what is happening. And we've seen just a few examples of negative patient outcomes. Nobody wants to be on the front page of the newspaper, right? And, that is not our goal. That certainly is not risk management's goal. And none of us want to feel like the care that we are providing is less than safe for our patients. And I know that that is our goal. That is our promise with our patient, right? That is what we do every day. We have that new, and we reestablish that covenant with the patients that we are there to serve, that we will do our best to provide them with best practice care, not one time, but every time they come into the facility, and with every person that they have some sort of interaction. In order to do that, we have to make sure that we understand the risks and we understand the procedures, and then we can help determine and set the course then for improved practice as both locations of care changes and methods of care change. So some of our takeaway points are: ultrasound is increasing dramatically, therefore we need to have a better understanding about where it is occurring and the risks. We need to be looking at uses of ultrasound so we can make appropriate determinations on how to use them under conditions that meet the criteria or classifications as semi-critical and critical use. The same standard of care has to be applied across your setting. You need to be an equal opportunity infection preventionist, that it doesn't matter where that patient is seen or when they're seen, everybody has equal opportunity for receiving best practice care. Our survey showed that we've got a lot of variability, and we need to understand that variability. And compliance with existing best practice is a problem. And it's not because people don't want to. What is the barrier? What are the barriers to keeping that from happening? And that we are going to have to develop an action plan. And an action plan is going to have to be based upon what is the gap between actual practice and best practice, and that we know we'll have to have the number of tools and resources to actually enable this to occur. Now with that, we'll have some time for some discussion from you, some comments, questions, things that maybe you have done that you think are relevant and that we can learn from, or problems that you have had that we can perhaps bring forward and say this is an aspect that we need to include.